Hi, I'm Dr. Jack West, and I'm an associate clinical professor in medical oncology at the City of Hope Comprehensive Cancer Center in the Los Angeles area. When we're doing molecular testing, we are typically looking for a driver mutation like an EGFR mutation or an ALK rearrangement or ROS1. And we're also looking at tumor PD-L1 expression. And we're kind of conditioned to say, oh, if I find an EGFR mutation, I know what to do. I'm going to reach for osimertinib. If I see that a patient has high PD-L1, I know that pembrolizumab is an excellent choice for this patient. Sometimes you'll find that people have both of those. So you seem to be pulled in two directions. In these cases, the vast majority of the time, the right answer is going to be to favor the driver mutation for a few reasons. One, while it's important to acknowledge that not all driver mutations are the same, in most cases, the value of treating with a targeted therapy for patients with a driver mutation is going to be greater than for treating with immunotherapy for high PD-L1 if they have both. That's because the bar is set very high with an agent like alectinib for ALK positive or osimertinib for EGFR mutation positive, where the response rates are in the range of 70, 80%. And these patients are typically on these therapies for years rather than months. It's hard to do better than that. And so we would really prioritize the targeted therapy. Another thing is that in the setting of EGFR mutation or ALK rearrangement, it's not clear that PD-L1, the tumor PD-L1 expression even has the same meaning. There are a lot of patients, particularly with ALK rearrangements, who also have high PD-L1, but they don't tend to get the same benefit from immunotherapy that you'd expect from patients with wild type. It's also been seen in patients with an EGFR mutation. So you can be faked out by high PD-L1 in these patients with a driver mutation. And for this reason, while I would give immunotherapy at some point for these patients, it would not be the frontline approach. And I would definitely favor the targeted therapy for patients who have a driver mutation identified. Now, a possible exception would be, as I said, not all driver mutations are the same. Patients with a BRAF V600E mutation seem to benefit from immunotherapy pretty comparably to those with who are wild type for BRAF V600E. And the efficacy of that therapy with dabrafenib and trametinib for BRAF V600E is strong, but it's got toxicity issues, and some people might not clearly prefer that as first-line therapy. I think it would be debatable whether to favor an immunotherapy or chemoimmunotherapy approach for these patients over dabrafenib and trametinib. I don't think either would be wrong in that case. And I would also say that KRAS G12C, while not having a standard therapy today, as of early 2021, we are likely to have therapies starting with sotorasib very soon for KRAS G12C, but that has really been studied and has efficacy demonstrated in previously treated patients, and an efficacy that doesn't really eclipse what you'd expect to see from immunotherapy. Moreover, patients who have a KRAS mutation appear to get all of the benefit that you'd expect from patients with KRAS wild type, if not more. So it does depend on the driver mutation we're talking about, but if we are focusing on EGFR, ALK, ROS1, et cetera, these are cases where I would definitely prioritize targeted therapy for those driver mutations over immunotherapy based on them also having high tumor PD-L1 status.